A very good afternoon to all. Studies on outcomes of lacrimal gland biopsy, a clinicopathological study. Due to the diversity of lacrimal gland disorders, a tissue diagnosis is encouraged for definitive diagnosis and appropriate management. So we studied demographics, clinical presentations, imaging features, and histopathology of biopsied lacrimal gland lesions. This was a retrospective observational study of a total of 37 patients. Only incisional biopsies were included. Excisional biopsies, non-viral etiology, and epithelial neoplasms were excluded from the study. This was carried out in a tertiary care center over the past 10 years. The mean age at presentation was 43.70 years, which was ranging between 15 to 76 years. All were females except 3 males. The mean duration of symptoms was 10.93 months. A lid swelling was the most common symptom noticed in 33 patients, followed by pain, redness, blurred vision, dry eyes, dry mouth, watering, ocular irritation, and hearing loss. So, a total of 34 patients presented with lid edema, of which 12 patients had mechanical ptosis. An enlarged palpebral lobe of the lacrimal gland was seen in 30 patients. Supratemporal conjunctival congestion, which was characteristic of lacrimal gland inflammation, was seen in 6 patients. A palpable mass in the supratemporal orbit was seen in 4 patients. Other signs noticed were parotid gland enlargement, tenderness, proptosis, preauricular lymph node enlargement. The blood investigation showed a normal level of serum inflammatory markers, including ESR and CRP, in 23.33% cases of lacrimal gland inflammation. ESR was raised in 40% cases of inflammation and 42.86% of lymphoproliferative lesions. The CRP was raised only in 8 cases of lacrimal gland inflammation. So this shows that a normal level of serum inflammatory marker does not exclude any inflammatory pathology, and also in even in neoplastic etiologies, the inflammatory markers could be raised. The raised serum angiotensin converting enzyme was seen in 2 patients with the granulomatous inflammation, 2 cases of Sjogren's disease, and 1 patient with the IgG4 related orbital inflammation. Both cases of granulomatosis with polyangiitis, that is GPA, showed positivity for P-ANCA. Imaging was done in all patients, CT in 26 patients, MRI in 11 patients. The shape of the lacrimal gland was maintained in 31 patients. This was a case of sarcoidosis. Here we can see that both lacrimal glands are enlarged, but the shape is maintained. And it was lost in 6 cases. The characteristic molding around the globe, which was a feature of lymphoma, was seen in only 2 cases of the lymphoproliferative lesions. So this was a patient with lymphoma. Here we can see that the mass is characteristically molding around the globe. This was again another patient with a lymphoma, but here that feature was not there, only the lacrimal gland was slightly bulky. Intracorneal extension was seen in 1 patient, globe indentation was seen in 2 patients, and scleral thickening in 1. So this was the histopathology diagnosis and the management. A total of 16 patients were found to have non-specific inflammation, and 14 patients had specific inflammation, which included 4 patients with granulomatous inflammation, 3 with IgG4 related cases, 2 with GPA, and 3 with Sjogren's disease, 1 parasitic granuloma, and 1 xanthogranulomatous inflammation. Lymphoproliferative lesions were seen in total of 7 patients, including 5 cases of lymphoma, 1 case of reactive lymphoid hyperplasia, and 1 Castleman disease. Patients were treated with different modalities, including oral steroids, immunosuppressants, disease-modifying anti-rheumatoid drugs, and biologicals, and also chemotherapy and external beam radiotherapy in case of lymphoproliferative lesions. We did a subgroup analysis between the non-specific and specific inflammatory group in terms of age, duration of symptoms, and clinical features and gender. There was no difference in any of these features. So these were all different patients with a different diagnosis, including sarcoma, IgG4 related inflammation, lymphomas. But here we can see that all of them presented with a clinical feature of lid swelling, and the lacrimal gland is enlarged and congested. But when it comes to laterality, we can see that out of the 16 patients with non-specific inflammation, 11 were unilateral, and out of the 14 patients with specific inflammation, 11 were bilateral. So this was statistically significant, suggesting that when the patients present with a bilateral disease, that is more suggestive of a specific etiology. Associated systemic involvement was seen in total of 7 patients. This was seen in cases of GPA, sarcoidosis, granulomatous inflammation, and in one was a known case of non-Hodgkin's lymphoma, and also in case of xanthogranulomatous inflammation. The median follow-up duration was 6 months. 10 patients were lost to follow-up. Complete resolution was seen in 22, and 5 patients were still under treatment at the last follow-up visit. So this was a lady with a 23-year-old lady who presented with bilateral redness and swelling of the eyelids. On examination, she had both eyes this enlarged and slightly congested lacrimal gland. The imaging showed an enlarged lacrimal gland which with a contiguous inflammation extending posteriorly. So in this, we did a blood investigation which showed a raised RF factor and ESR, but CRP and AC was negative. So the biopsy was done, which showed features suggestive of IgG4 related orbital inflammation, including reactive lymphoid follicle in the lacrimal gland. There was concentric fibrosis around the lacrimal ducts. There was phlebitis. There was fibrosclerosis. And immunohistochemistry was done, which showed IgG4 plus positive cells suggestive of IgG4 related orbital inflammation. The literature suggests lacrimal gland insertion biopsy in patients who do not respond rapidly to antibiotic therapy, but how rapidly it is not defined. Though a course of oral steroids is preferred prior to biopsy, it can lead to misleading phenomenon of clinical improvement because of apoptosis in lymphocytic lesions. So it will be ideal to consider orbital biopsy first in orbital inflammation, especially in lacrimal gland inflammation. So we have different approaches for taking a biopsy. We can either go by an anterolateral orbitotomy or a transeptal approach. So what is important is differentiating it from the fat, that the preaponeurotic fat, that is totally yellowish in color. The lacrimal gland will be slightly firmer in consistency and more pale pink in color. A biopsy sample should be minimum of 2 into 2 into 2 millimeter, and it is always important to take a deep biopsy also. So we compared with the previous few studies. Here it shows that around 38 to 43% had non-specific inflammation in all the studies, but altogether the specific and lymphoproliferative etiologies could be seen in more than 50% of cases in all the studies. To conclude, a low threshold for lacrimal gland biopsy is advocated, especially in case of bilateral involvement. Thank you.
Nice collection of cases. Thanks.